Good morning, everyone. On behalf of the Sri Lanka Association of Clinical Pharmacology and Therapeutics and the Sri Lanka College of Internal Medicine, it's my great pleasure to welcome you all to the joint CME webinar conducted by the SLACPT and SLSIM in collaboration on clinical toxicology. This collaborative academic initiative reflects the shared commitment of SLACPT and SLSIM to strengthen the knowledge and to promote safe therapeutic practices and enhance the capacity of clinicians to manage toxicological emergencies and medication-related harms. Today, we are going to have a series of lectures with clinical correlation delivered by the clinical experts in the field of toxicology. Clinical toxicology remains a critically important area in medical practice, from medication overdose and adverse drug reaction to exposure to recreational and psychotropic substances. So today we are going to take you through this a series of topics on clinical toxicology in practice. To officially inaugurate today's webinar, may I kindly invite Professor Chandani Vanigatunga, Senior Professor, Chair Professor of Pharmacology, Faculty of Medical Sciences, University of Vijayawardhanapura, and the President of Sri Lanka Association of Clinical Pharmacology and Therapeutics, to welcome you all and to address the gathering. Over to you, Madam.
Thank you very much, Sahan, and good morning, everyone. Welcome to this joint webinar on clinical toxicology that we have planned in collaboration with the Sri Lanka College of Internal Medicine. While pharmacology spans across all medical specialties, it is particularly relevant for toxicology because this is where we look at the basic pharmacological principles and how they interact to improve the toxicology problems and to improve their management. To do this today, we have an evident galaxy of people who are actively involved in patient management related to toxicology, and that is, again, a huge positive impact on what we are planning to do. I'm deeply grateful to the Sri Lanka College of Internal Medicine for accepting our invitation. And I'm particularly glad that our first activity for this year, the joint webinars that we plan throughout the year, is with the Sri Lanka College of Internal Medicine, a college that holds a special place in my heart. I'm grateful to its president and the members for joining us today and for facilitating this activity. I'm sure that all of us here will learn a lot. More importantly, practices that will have an impact on our day-to-day work when we are faced with a patient with a toxicological problem. So thank you very much, everyone. And before I hand over back to Sahan, I'd like to thank Sahan for taking all the trouble. Sahan is our Assistant Secretary of the SLACPT for taking all the trouble to coordinate this activity and to find the resource persons and to make sure that this becomes a reality. So thank you very much, Sahan. And thank you very much, everyone, for joining. And I hope you have a very fruitful morning as we go on. Over to you, Sahan.
Thank you very much, Madam. So now it's my pleasure to invite Dr. Dirosha Madhuvanti Hettiarachchi, the President of Sri Lanka College of Internal Medicine, to welcome the gathering and to address the audience. Over to you, Madam.
Thank you very much, Sahan. As the President of Sri Lanka College of Internal Medicine, I would like to sincerely thank the Sri Lanka Association of Clinical Pharmacology and Therapeutics for the valuable collaboration in organizing this joint CME webinar on clinical toxicology. And my special thanks goes to the President SLCPT, Professor Chandani Vanikutinga, for her leadership and support in making this collaborative academic program possible. And I would also like to thank Dr. Sahan Mendis for facilitating this collaboration and for his efforts in coordinating this important initiative. And this kind of collaborative academic engagement strongly aligns with our theme for the year 2026, a decade of inspiration and a future of innovation. By bringing together expertise-related disciplines, we strengthen the knowledge sharing and encourage innovative thinking, as well as ultimately enhancing the quality of patient care. And my sincere thanks also goes to all the speakers and participants whose contribution make this session more meaningful and successful. Thank you very much.
Thank you, madam. So, without further ado, let's start our webinar on clinical toxicology in practice. So, I would like to invite Dr. Madhuvanti Hettiarachchi, the specialist in internal medicine, toxicology unit, Teaching Hospital Peradeniya, and the president of Sri Lanka College of Internal Medicine, to deliver the first lecture of this webinar, An Approach to Management of Medication Overdose. Over to you, madam. We can't hear, madam. I think.
Madhu, you are muted.
Right.
Can you see it now?
Yes. No, madam. I think. Now can see.
Okay, yeah. So during the next 20 minutes, this is my approach. I would be discussing a little bit about the general approach to a patient with medication overdose, and then discuss about the toxidromic approach. And when you are managing a patient with poisoning, you have to go according to the rhesus RSI pathway, which I would discuss in detail. So let's start our talk with a case scenario. We have got this 36-year-old male presented with a history of aggressiveness, and he's complaining that someone is coming to kill him. And he used to live alone and has a history of depression, and he's on medication for that. And on examination, he was confused, agitated, and combative. And his temperature was about 38 degrees Celsius with a dry skin. And the pupils are dilated, and the pulse rate is about 108. Blood pressure is on the high side, 152/88. And on examination, his bladder was also palpable. So now when you're coming to the diagnosis, you have to think about several differential diagnoses, including a toxicological diagnosis. So when you see a patient, critically ill patient like this, you will anyway uh, take your short history and look for any clues and do certain investigations. So this is what we will do in this particular case as well. So as I said before, we usually go with the rhesus RSI dead pathway, which is a mnemonic. We used to, for the protocol management of patient with poisoning. Then before that happens, since you don't know what the patient has taken, it's very important to apply a toxidromic approach to come at a diagnosis. So it's actually a very simple approach that you can use only the clinical signs, like in the size of the pupils, skin secretions, vital signs, and mental status. So by using these simple clinical assessment, you can come to a diagnosis. So as I said before, when a patient does not reveal the poison the patient has taken, differentiating it from other pathologies might be a major challenge. Then differentiating from which poison the patient has taken is also becomes a major challenge. So that's where the toxidromic approach will be very useful, as I said before. So what is a toxidrome? It's a constellation of clinical symptoms and signs associated with a class of toxin, and based on the autonomic effect that particular toxin in question exerts, you can divide into 5 major toxidromes. Usually different classes causes different autonomic features, so it will become very handy when you are trying to come to a diagnosis of the certain toxidromes. So, as earlier mentioned, your identification relies on readily observable findings such as the size of the pupil, the skin secretions, vital signs, and the mental status. So, these allow a rapid narrowing of your toxicological differentiation. So there are five major toxidromes that we usually encounter in toxicology. So the cholinergic, anticholinergic, sympathomimetic, sedative, hypnotic, and opioid toxidrome are the most common ones. And there are other uncommon toxidromes such as serotonin syndrome or neuroleptic malignant syndrome. So I'm going to tell you a simple pathway how to differentiate between these five toxidromes. So if your patient is agitated, there are only two toxidromes which are possible out of these five toxidromes. So you need to go ahead, and look at the blood pressure, pulse rate, and the temperature and the respiratory rate. If all these are elevated and your pupil size is also dilated, the only differentiating feature to distinguish between whether it is anticholinergic toxidrome or the sympathomimetic toxidrome is by looking at the skin secretions. If your skin secretions are very dry, very hot skin, then it's most probably the anticholinergic toxidrome. If your skin is very wet and diaphoretic, it's the sympathomimetic toxidrome. As you're aware, when you are in a flight and fight mode, you become very sweaty. So that is how, when the patient is agitated, you differentiate between these two toxidromes. If your patient is somnolent or drowsy, there are three toxidromes which are possible: opioid toxidrome, sedative hypnotic toxidrome, and the cholinergic toxidrome. But when you take the cholinergic toxidrome, it's the quite opposite of anticholinergic toxidrome. Your blood pressure, pulse rate, and the temperature will be low, so will be the respiration. You'll be seeing pinpoint pupils with lot of copious wet secretions. So you'll be basically pouring out secretions from every orifice. So that's as you're aware, there's a mnemonic called dumbbells to remember all these features of cholinergic toxidrome. So if your blood pressure is low, the pulse rate is low, and the temperature is low, probably because you're sort of very wet with secretions, then you think of, with pinpoint pupils, you think whether the patient is having cholinergic toxidrome. But if your patient is more or less having a normal blood pressure, or sometimes it might be low blood pressure also with pulse rate and temperature, and your respiration is very depressed with pinpoint pupils, you have to think whether this patient is having a opioid toxidrome. The patient's secretions will be normal. And if the patient is having normal size pupils with normal or slightly depressed respiration, then you have to think whether the patient is having sedative hypnotic toxidrome. So this is a kind of a very simple pathway for you to differentiate between these five toxidromes. Okay, now this is the summarized version of what we have been talking about earlier. I'm not going to go into details of this. Now, if you go back to our patient, now there are certain clues in the history that you can use to apply for that simple pathway that we have talked about. The patient is clearly agitated. So what are the two things which is possible out of those five toxidromes? The sympathomimetic and the anticholinergic toxidrome. Since he's having very high temperature and dry skin, what is the most possible scenario at this moment? So it has to be an anticholinergic toxidrome. Okay, now we have got a tentative diagnosis for this patient. So you can remember this again as with this small poem that we have been using when we were medical student. Hot as a hair, we try to say that he has warm skin, dry as a bone because dry skin and mouth, blind as a bat because the patient has mydriasis, red as a beet because the patient is having flushed skin, and mad as a hatter because he's having agitated and having hallucinations, and full as a flask because there's urinary retention. The most probable causes are atropine plants like datura, mushrooms, tricyclic antidepressants, and antihistamines. Now, when you talk about this toxidromic approach, you try to come to a differential diagnosis, and then now when as this patient is critically ill, you go according to the rhesus RSI dead pathway, the protocol for management of a patient with unknown poisoning. Now please remember, although we say this according to this order, it does not mean I mean, every time that you need to apply this also. You might have to give the antidote in a patient who is coming with organophosphate poisoning as a first instance after putting 2 wide bore cannula. That depends on the particular toxin involved, especially in a patient who is coming with very depressed respiration. You might have to give a, if you are suspecting a opioid toxidrome, you might have to give an naloxone in that case at least to diagnose a patient. So initially will be resuscitating the patient, airway breathing circulation, and D is for disability and E is for exposure. These two are also very important in a patient who is coming with unknown poisoning. You need to look at the RBS also, see whether there's any neurological involvement, and look at the exposure and try to get rid of the exposed material as much as possible. Sometimes you might have to clean and remove, clean the skin and remove the clothes also. So as I said before, in any patient who is coming with critically ill condition, you need to take a short history. It has to be very short, but you need to be focused as well to come to a complete diagnosis. So in this case, that you need to ask from the patient or the patient's relative time the patient was seen last. Well, you might have to count the remaining tablets if they have produced tablets, and look at the labels for the poisons, blister packs, sachets, and see whether the patient consumed any intermediate release preparation or sustained release preparations. Look at the clinic notes of the patients or the relatives, ask whether the patient has vomited at home, and look at the color and content of the vomiters, and if there are any poison particles, tablets, you can have a look at that as well. And it's very important for you to know the time taken for the patient to reach the hospital, because the further management will depend on that as well. And management done at the peripheral hospital is also very important, and please make sure you make a special note of what you have done, because as in any patient who is critically ill, sometimes for ischemic heart disease, you say time is muscle and time is brain. So here I say time is life, because if you don't use that important time to do the initial stabilization of the patient, you will lose the patient. Now here this history is very important to assess the risk of this patient. So in our research RSID pathway, you can have a look at the risk the patient is having by adding certain other questions, such as whether the patient has been depressed, whether this patient has written any suicidal notes, how is the blood pressure and the vitals of the patient. So after checking all these things, you come to an understanding the risk the patient is having, and then try to put the patient on supportive or symptomatic care, which might consist of IV fluids, antiemetics, and sometimes inotropes. And then you try to do the investigations, which will be essential. So if any patient who is coming with poisoning, arterial blood gas is a very important bedside test that you can use. It will give you a diagnosis, as well as it will be very helpful in the management as well. Why I said arterial blood gas, not the venous blood gas, is usually these patients are compromised, respiratory compromise will be there. There will be a lot of aspiration. There can be a lot of uh, uh, sort of secretions which have gone into the lungs, and yeah, we may be compromised. And due to the drug effect itself, the respiratory efforts will be depressed. So it is important for you to know the actual oxygenation of the body. And as I said before, by looking at the pH of the patient, you can see with what kind of um, medication the patient must have taken. So as an example, I can say in a metformin poisoning, you will see there will be metabolic acidosis. So by looking at the anion gap, which will be very useful in diagnosing patients with toxicological poisoning. So to calculate that, the ABG would be quite helpful, as well as the electrolytes. And as I said before, RBS you'll be doing anyway when you are doing the ABCD assessment. That is very helpful. The patient might be having low sugar levels, and the ECG, because all these toxins, medications, and other poisons also can cause lot of electrolyte imbalances. They can the patient might be having a lot of GI effects, the vomiting, diarrhea, and everything can result in electrolyte imbalances, as well as this blockage of certain sodium potassium pumps, and everything can result in cardiac arrhythmia. So ECG is a must in any patient who is coming with poisoning. Other investigations, of course, you can do accordingly, and they will be helpful in managing these patients. So why it is important for us to assess these patients first. If the patient has taken a potentially life-threatening amount of poison, especially in the case of a country like Sri Lanka, gastric lavage do have a place. If the patient comes within 2 hours, that is very much useful. But even if the patient presents little late, if the patient has taken a large amount, about within 6 to 8 hours of presentation, we have done the lavage. As clinicians, we have experienced that it has actually a good outcome. And you can give the activated charcoal. These are actually called decontamination procedures. The whole bowel irrigation also comes under decontamination. So what not to do in a patient with poisoning? Never induce vomiting, because this has been done in the past, and they are the most of the peripheral unit doctors, they actually do the induction of vomiting, and they mention that they have done the gastric lavage, which is actually very, very wrong. So please do not induce any vomiting. And if the patient comes within first 1 to 2 hours, as per the guidelines, you can do the gastric lavage carefully. When the patient is fully conscious. If not, the patient is conscious, then you have to intubate the patient, and then after a cuff TT tube is inserted only, then you perform the gastric lavage, especially in a patient with poisoning. If the GCS is less than 10, it's better to put the ET tube to prevent aspiration. And when you're doing the gastric lavage, make sure you take the informed consent. Cuff TT tube usually is necessary. NG tube 18 gauge is above is fine, and you have to confirm the correct placement. Usually the first 50 ml of gastric lavage has to be taken for the toxicological analysis and the medical legal purposes. Lavage fluid can be either normal saline or water. Recommended volume is about 200 ml for adults. You usually put 200 ml in, and then you take it out. So around 3 liters of lavage fluid will be sufficient to do that, or else you might have to do it until your return comes out clear. So when is gastric lavage is contraindicated? If the patient is really struggling and uncooperative, don't do it, because you might have the risk of aspiration. Again, if the patients are at high risk of aspiration with low GCS and all, you have to be careful. I said before, you need to put an ET tube and cuff it and then do it. And patients who have taken strong caustics or corrosives or volatile hydrocarbons like kerosene, turpentine, please don't do the gastric lavage. So what is activated charcoal? It's a charcoal. It can adsorb certain poisons. If the patient presents within 1 to 2 hours of ingestion, you can ask the patient to drink it. So drinking is much more comfortable than than giving through an NG. Dose is usually 1 gram per kg. Usually the bottle comes with 50 grams of activated charcoal. Maximum is 50 grams. Usually you dilute in 200 ml of water, dissolve it, and get the patient to drink it. So if the patient is unconscious, of course, you need to put the ET tube. After cuffing it, you give the activated charcoal via the NG tube. And if multiple doses are indicated, you need to give it 50 gram every 4 hours, 24 to 48 hours. Now, multiple doses again comes under enhancing the elimination. We'll talk about it later. Activated charcoal is contraindicated if the patient is having compromised airway reflexes, and unless they are intubated. If the patient has taken caustic substances, late presentation, and increased and has severity of high risk of aspiration, especially hydrocarbon ingestions and caustic injections. If you have to do an endoscopy, in case of significant caustic injection, you might have to do an endoscopy. So if you give activated charcoal, you might not be able to see the upper GI properly. So don't give activated charcoal in cases like that. And there will be poor absorption of activated charcoal in cases of metal poisoning, like iron, lithium, alkali, mineral acids, and alcohol. So don't give any charcoal for those things. Also, there will be poor absorption. So if you have the patient has presence of intestinal obstruction, it's an absolute contraindication to give charcoal, because this used charcoal can go and impact on the bowel loops, and there can be a risk of perforation. And again, relative contraindication is that decreased peristalsis. So if you have to give multiple doses of activated charcoal, that means the patients will be having um, intrahepatic, there's a chance that poison can enter the intrahepatic circulation. So in those cases, you will have to give multiple doses of activated charcoal, as well as the patient has taken extended release or slow release preparations also. You might have to give multi-dose activated charcoal in the case of Elolienter, Niangala, and slow release medication, extended release preparations, quinine, theophylline, carbamazepine, and dapsone. You'll be giving multiple doses of activated charcoal. So what are the methods of enhancing elimination? As I said before, it's a multi-dose activated charcoal is a method of enhancing elimination. You can use urinary alkalization, urinary acidification, dialysis, hemodialysis, CVVH, CRRT, SLAD. This according to the medication the patient has taken. These things can vary. You can sometimes apply plasma exchange transfusions, and ECMO also. So consider enhancing elimination in the severe poisoning plus dialysable drugs plus impaired clearance. So the poor candidates for dialysis are if the patient has taken highly protein-bound drugs, large volume of distribution, and lipophilic drugs stored in tissues. So that can cause the patient will not have actually more benefit of doing a hemodialysis. So hemodialysis are usually best for lithium, methanol, ethylene glycol, and salicylates. And as I said before, multi-dose activated charcoal is useful in these medications, which I have described earlier also. So antidotes, sometimes empirical treatment will be needed at the outset, as I described earlier. Naloxone in suspected opioid toxicity, and acetylcysteine for paracetamol injections, atropine for cholinergic toxicity, and sodium bicarbonate for TCA toxicity. And sometimes if the clinical suspicion is very high, you might have to do this even without drug levels, because we don't have many in many countries like us, we don't have the drug levels. So the last D here, we have discussed all these things. Last D is for disposition, where that is where you are going to put the patient, whether you are going to put the patient into the ICU, whether you are going to put the patient into the ward, or whether you are going to discharge the patient. So in this patient, as we discussed before, it's an anticholinergic toxidrome. You have to give a lot of fluids to prevent rhabdomyolysis in these sort of patients. To prevent agitation, benzodiazepines can be given. Again, the antidote is physostigmine, but you will not give it very you have to see whether the patient is having any seizure, if there's a real need only, that we will give physostigmine. If the patient is having seizures, sedation, delirium, narrow QRS, supraventricular tachyarrhythmia, or hemodynamic deterioration only, you will be giving physostigmine. So this is the summary of my talk. You need to stabilize the patient. First, ABCD approach. Treat reversible causes early. Use toxidromes to guide your diagnosis. Perform targeted investigations. Supportive care is the cornerstone. And use antidotes when indicated. Thank you very much.
Thank you very much, madam, for that comprehensive lecture on approach to management of medication overdose, how we approach a poison patient with drug overdose. So again, I would like to remind you all that the questions will be taken at the end of the four lectures. So there will be a Q&A session, and also we will share a QR code during that time for you to scan and enter your details into a Google form from which you will receive the CPD certificate. So this webinar awards CPD points for the participants. So next, we are going to move on to the next lecture of today's webinar, uh, which is on evidence-based management of paracetamol toxicity. This lecture will be delivered by Professor Priyadarshini Galapathy, Chair Professor of Pharmacology, Faculty of Medicine, University of Colombo. Professor Galapathy will talk to you about the management of paracetamol toxicity. Over to you, madam.
Thank you very much, Sahan, for the kind words of introduction. Can you hear me and see my slides?
Yes, madam. We can see the
Okay.
slides.
Okay, right. Okay, thank you. So, good morning to all of you. And first of all, let me thank the Sri Lanka College of Internal Medicine and Sri Lanka Association of Clinical Pharmacology and Therapeutics for inviting me to deliver this presentation. And it is particularly my pleasure to do this during the presidencies of Chandani and Madhuanti, and on a very important and pertinent topic. So this is the outline of my presentation. This is an evidence-based presentation, so therefore I will go through the recent guideline recommendations, particularly looking at four guidelines given from four countries, the Australia, New Zealand guideline, USA and Canada guideline, and UK, and of course our own Sri Lankan guidelines, comparing the different recommendations and what can we take from each of these. I will address the decontamination methodologies, the antidotes and the regimes recommended in different guidelines, the normograms used, of course, which is not really applicable to manage patients in Sri Lanka, but again, we need to be aware of those, the cutoffs, the toxic doses, and we'll look at some different case scenarios, the challenging situations, and then evidence-based key takeaways for managing patients in our own country. So paracetamol or acetaminophen as referred in the US was introduced as an analgesic in the 1950s. And as we all know, it's remarkably safe in therapeutic doses. And the first cases of paracetamol poisoning was reported in the BMJ in 1966. This is that article of two patients dying of acute liver necrosis following paracetamol overdose, where there was no antidote available. And over the years, the toxic doses have been identified, although still there is some controversy. And it could be actually the most studied drug in toxicology, according to publications. However, despite that, there are still many controversies that exist without consensus actually on interventions. And therefore, further assessment is needed with high quality multi-center RCTs, and some are still ongoing. These are two excellent articles which actually covers the clinical development of the antidotes, and then the research that has been done over the past 50 years or so. So I recommend anyone who is particularly interested in paracetamol overdose to read this. So the key relationship between paracetamol and toxicity was established in about 1971, and at that time that led to the development of this Rumac-Matthew normogram, which is used to identify those who require treatment with antidote. And so acetylcysteine was developed as the lead intravenous antidote in the UK. However, the license holder in the US refused to make an intravenous formulation. That is why in the US they were using oral acetylcysteine, but now they are also having the intravenous acetylcysteine. So I think most people are aware of the metabolism of paracetamol, which differs in therapeutic dosing and in overdose. So in therapeutic dosing, vast majority undergoes conjugation, and only a small percentage of 5 to 10% undergo oxidation, particularly by CYP2E1. And that produces the toxic metabolite NAPQI, which conjugates with glutathione. And in overdose, the capacity for conjugation with glucuronide and sulfate is exceeded, resulting in vast amount of NAPQI being formed, which combines with glutathione, where the stores gets quickly depleted, and therefore it's not N-acetylp benzoquinonimine is not detoxified, and that causes the liver and tissue injury. So this pharmacological mechanism is actually currently used in an ongoing trial which is testing a higher dose of NAC with the hypothesis that it will increase detoxification of paracetamol based on this pharmacology. So I mentioned the recent guidelines in major countries. So these are the guidelines. They have been published from 2020 onwards. The Australia, New Zealand in 2020, US, Canadian one 2023, as well as the BMJ latest update, the UK one in 2023. And I'm very happy that our own local guideline is 2024, which is particularly with main contributions from Madhuanti, and also launched in Suranga's year by the SLCIM, which is a very, very useful document for managing all kinds of poisoning, including paracetamol. So these are the common scenarios that are addressed in many of these guidelines. The most common one is acute ingestions of immediate release products. So this is defined as any intentional or deliberate paracetamol overdose within 24 hours. And the toxic doses considered varies to some extent between guidelines. I'll come to that in a moment. Then we also have the situation of multiple or staggered ingestions. So this is any staggered, that is the patient takes more than one dose over more than 2 hours apart. And if that has taken place within the first 24 hours, that is also considered as and managed as acute ingestions. Then we have the repeated supratherapeutic ingestions, where a toxic dose over a single 24-hour period or over a longer period, either 48 hours or more. And then high-risk ingestions, where ingestion of quite a higher dose, like some pay, say, 30 grams, some pay 50 grams, based on the amount ingested, and some guidelines use the acetaminophen or the paracetamol concentration to determine that it is a high-risk ingestion. So acute ingestions are the most common type of overdose encountered, which is what we also have found during the studies that were repeatedly done in Sri Lanka also. And the ingestion period is less than 24 hours, regardless of the pattern, whether it can be single or multiple ingestions. And multiple or staggered ingestions, if they have occurred within 24 hours, they are, as I mentioned, considered under acute ingestions in most guidelines. In contrast, a repeated supratherapeutic ingestion occurs during a period of greater than 24 hours, because the management differs here, because here then liver damage has already occurred, and therefore more N-acetylcysteine is required. So the critical, factor, particularly for our country, is the toxic dose for acute ingestions, because we don't have paracetamol levels readily available, and therefore whether it is toxic or very high doses or non-toxic, we have to determine based on the dose ingested. So the UK guideline says that serious toxicity may occur in patients if they have ingested more than 150 milligrams per kilogram in any 24-hour period. And toxicity is, but it can rarely occur between 75 and 150 milligram ingestion also. And if the dose is less than 75 milligram per kg, it is very unlikely to cause toxicity. And our Sri Lankan guideline gives an recommendation to use antidote if the dose ingested is more than 150 milligram per kilogram, which I think is a very rational and reasonable recommendation. The Australia-New Zealand guideline considers anything more than 10 grams or 200 milligram per kg, whichever is less, as the toxic dose. And the US and Canadian guidelines actually says anything more than 7.5 grams or toxic concentration in the nomogram as the toxic dose. You can see that there are, differences in the toxic dose recommended. This I find is a very useful article, published in 2022, because it is applicable to our setting. That is, what is the ingestion to treat when you are treating without the help of a paracetamol level. And it says that most countries use this 150 treatment line. I'll come in a moment to the nomograms. And the cutoff value, and they considered the UK guideline, which recommends, which is using a lower cutoff in the nomogram of 100 milligrams per deciliter as the cutoff point. And they have found where paracetamol concentration is not available and activated charcoal is readily used, and if you're using the UK guideline, an ingested dose of more than 150 milligram per kg as the cutoff for N-acetylcysteine identifies most of the patients who need treatment, because it gave a sensitivity of 82% and specificity of 73%. Right, now coming on to managing patients, gastric decontamination. So 50 grams of activated charcoal should be administered to a cooperative awake adult if they are admitted within 2 hours of ingestion, is what is given in the Australia New Zealand guideline. And they also say that if the overdose was very high, like more than 30 grams, then activated charcoal should be given within up to about period of 4 hours. Of course, with low evidence, but strong recommendation. And US Canadian guideline actually recommends activated charcoal to be given within 4 hours. And the UK guideline says within 1 hour. If the excess dose is more than 150 milligram per kg. And our local guideline actually under paracetamol overdose does not specifically talk about gastric decontamination, says that gastric lavage and activated charcoal play a role, and to use the general GI contamination guideline, which actually Madhuanti beautifully explained under resuscitate guideline. So there are 150 to 100 grams as a single dose, and says within 1 to 2 hours to be given. Right. So focusing a bit more on the Australia New Zealand guideline, the main recommendations that are unchanged from this, the 2021, from previous guidelines are that patients presenting early should be given activated charcoal, and they should be given acetylcysteine if they are at risk of hepatotoxicity. And the nomogram used to assess the need for treatment should be used to guide N-acetylcysteine. And those who require different management are if they have modified release paracetamol ingested or large or massive doses, and accidental liquid ingestion in children, and repeated supratherapeutic ingestions. And the major changes in the guideline is the use of the two-bag regime, which is 200 milligrams over 4 hours and 100 milligram per kg over 16 hours of acetylcysteine, because it has similar efficacy but significantly reduced adverse reactions compared to the previous three-bag regime. We were also using the previous three-bag regime, but here also now it's a two-bag regime, which is recommended by the SLCIM, which we are using. So massive doses with high concentrations need higher doses, and then they address the modified release preparations, where they should receive full course and then maybe extended treatment. And again, very high dosing requiring increased acetylcysteine. So coming to the NAC regimes, we are using three different regimes in different countries. So the three-bag regime, which was used earlier, that is a loading dose of 150 milligram per kg over 15 minutes, followed by 50 milligram per kg over 4 hours and 100 milligram per kg over 16 hours. So now many people are not using this because these were associated with more adverse drug reactions. And the UK is using this Scottish and Newcastle SNAP protocol, which is a two-bag 12-hour regime. And many are using the two-bag 20-hour regime, which is the Australian one. Australia, New Zealand one, and that is the one which is recommended in Sri Lanka also currently. So this is the basis on which the trial based, which actually gave this two-bag 20-hour regime, and it was found to be non-inferior to the three-bag regime, and it decreased the non-allergic anaphylactic reactions and GI adverse effects also. What is the US recommendation? So they say use the FDA approved, published, or another published IV or oral protocol, delivering a minimum of 300 milligram per kg over 20 to 24 hours. So they say over 20 to 24 hours. So whereas UK one is the 12-hour one, and they say to start NAC immediately if the dose is very high, and if you are using a loading dose of 150 milligram, then to use a three-bag regime, and if you are using that, to give it over 1 hour rather than giving it over 20 minutes. So with these controversies, currently there is another trial that is undergoing in the UK. It is started in 2024 and a 2-year study. So hopefully it will finish this year. And they are testing two higher doses. Now, what is used in different regimes is the 300 milligram per kg one, but this trial is testing the 400 milligram per kg and 600 milligram per kg, and it is based on the paracetamol metabolism, and they are checking the metabolites also in patients. So treatment lines, as I mentioned, many lines are used. So the one of the most commonly used one is the Australia, New Zealand. This is the one that we were also using earlier, which is starting at 150 milligram per liter or 150 microgram per deciliter, starting at 4 hours, and then at 20 hours, about 20 milligrams per deciliter. And it's a curved line. And the US and Canadian line, again, 150, starting point of 150 milligram at 4 hours. But the high risk line is starting at 300 milligrams per liter, and then coming down. So they say if the concentration is above this high risk line, you have to use higher dose of NAC and for an extended period. And this is the UK graph. UK graph, this is given in the BNF, and which is endorsed currently by the MHRA UK, is a lower treatment line starting at 100 milligrams per liter and the low coming at a lower level, because they found that there are few patients develop liver toxicity if they use the 150 milligram per kg, 150 milligram per liter starting point. And this is our local graph. Again, it is actually using the 100 milligram per liter starting point, but it is actually, very often cannot be used in our setting because we don't have this paracetamol levels to guide our decisions. Many adverse events are actually noted. Minor anaphylactoid reactions, hypotension, and few cases of serious reactions, angioedema, hypotension, and even death. And most of these were caused by giving wrong calculated dose or too rapid infusion. And giving NAC to smaller injections cause more adverse drug reactions. So that's another thing that we need to keep in mind. So this is a case of in UK, some children who were given the SNAP 12-hour regime, they have noted some acute kidney injury, particularly in children. So there are concerns about that regime also. So again, this is the Australia New Zealand acute immediate release injection guideline. That actually is not really applicable to us because it is based on the paracetamol level. So what is applicable to us is the one that is management without paracetamol level. So if it is a high dose, if it is the dose is less, then and patient is asymptomatic, you don't start anything. Whereas if it is a toxic dose and less than 2 hours, you give the activated charcoal and commence acetylcysteine. And if it is very high, and then commence acetylcysteine, and they say to transfer to a better place. And then duration of NAC is another question that is addressed. So acetylcysteine should be continued until stopping criteria are met. The one of the main stopping criteria is ALT and the paracetamol level. So these are the stopping criteria. ALT or AST are decreasing, lower INR, and the patient is clinically well. And of course, they consider the paracetamol level also. In very high ingestions, second bag in the 2 bag regime, you double the concentration to 200 milligram per kg instead of the 100 milligram per kg over 16 hours. And sometimes even higher doses are used. And fomepizole, which is can be given as an adjunct, which we use in conditions like ethylene glycol and methanol poisoning, because it inhibits the CYP2E1 and it reduces the NAPQI formation. Multiple staggered overdose is a very important one because this is anything occurring more than 2 hours after ingestion. They are treated as per acute ingestions if it is within a period of 24 hours, as I mentioned. But the most dangerous one is repeated supratherapeutic ingestion. There is little evidence to guide risk assessment. Hepatotoxicity has been reported in therapeutic doses sometimes, particularly in depending on the age, alcohol use, nutritional status, and so on. This is a very unfortunate situation. These keep on occurring. A 7-year-old child dying of paracetamol overdose because it was dispensed, wrapped up in a piece of paper, and inside the adult dose was written as 2:3. Outside they have written that as 1:3, but the parents have used what was there inside. So repeated supratherapeutic ingestion they define based on the paracetamol level, and small fluctuations of ALT can occur, but all patients who have higher ALT of more than 50 should receive an acetylcysteine, and for a prolonged period also. So this is the SLCIM, our guideline. And so it recommends a 2-bag 20-hour regime similar to the Australian one. And it also considers NAC versus methionine. We were actually earlier recommending methionine if the patient admitted within 8 hours and asymptomatic, and if they don't have vomiting. But it is actually less of, I'll come to that in a moment. So challenges, in the interest of time, I will actually skip these 10 challenging situations. Most of those, like high risk of toxicity, hypersensitivity, late presentations, massive ingestions, and multiple doses, repeated supratherapeutic, modified release, pediatric toxic exposure in pregnancy, and co-administration with other drugs. So in 2015, I wrote this article with Professor Andrew Dawson on the relevance of recent evidence for managing patients in Sri Lanka. So most of these are still applicable with few changes. So we still don't have paracetamol levels to guide our treatment. And at that time, the 12-hour SNAP regime was used, but now we are using the 20-hour one. Medication errors in administering paracetamol is the main problem here. So education of prescribers, mothers, public is required. Cautious in using maximum dose of paracetamol in adults is required, particularly those who are having a lower body weight. We need to calculate based on the body weight. Few things before I finish. Cost of the antidote. In a presentation that I did in 2006, I have compared the cost. So N-acetylcysteine, the cost per treatment was 10,000, and methionine it was 2,000 not. So that's why we were favoring methionine, particularly for those who are admitted before 8 hours and smaller doses, small overdoses. But now in 2024, I find that cost of NAC has come down actually. I was also surprised to find this. So now the treatment cost is about 2,600. So which is quite a good thing. And we have spent for NAC in 2005 about 19 million, and now about 2024 31 million. Of course, we are using NAC for many other things, so therefore this is not only for paracetamol overdose. And methionine actually has been discontinued from 2021, 2022, so therefore it's not available in the hospital. So I don't think therefore we need to consider that in treatment. So these are the supplies from MSD. I had these slides from my previous presentations, but so now in 2024, 104,000, and 25 less probably due to shortage. So challenges for management in Sri Lanka, non-availability of level is a major problem, and monitoring facilities are limited, and of course liver transplantation is not available. Key takeaways for management in Sri Lanka. I think we can use activated charcoal up to 4-hour period since ingestion, because particularly we are managing without paracetamol levels, but no place for emesis or gastric lavage because no guideline or evidence talks about it now. The only antidote is now acetylcysteine, and which is now cheaper. We can start if more than 150 milligram per kg toxic dose is ingested. And we can't apply the normogram. And 20-hour 2-bag regime, which gives a total dose of 300 milligram per kg, seems to be the best option at the moment. And we will need higher doses and extension of treatment for higher ingestions, and monitor ALT before stopping, and treat repeated supratherapeutic injections repeatedly, vigorously. Thank you. I'm happy to answer any questions during the question time.
Thank you very much, madam. Thank you for that insightful evidence-based lecture on management of paracetamol toxicity. Our next lecture will be on psychotropic drug toxicity. a toxidrome-guided mechanistic approach. So this lecture will be delivered by Dr. Atula Kulasinghe, specialist in internal medicine, toxicology unit, teaching hospital, Peradeniya. Over to you, sir.
Good morning, all of you. Can you hear me and show me?
Yes, sir, we can hear you.
Okay, thank you so much for your attendance and good morning. And you all are welcome and thank you very much for the coordinators. So my topic is psychotropic drug toxicity, a toxidrome guided mechanistic approach. In this mini lecture, I'm going to discuss about with you regarding the mainly the clinical approach because the drug level assessment in Sri Lanka is very remote and because some of the patients are deteriorate very drastically, so clinical knowledge, bedside clinical knowledge for the clinicians are very important. So we have to train our juniors also how to assess bedside the level of toxicity, kind of toxicity, and we must familiar our juniors to the clinical methods, right? That is the purpose of doing this mini lecture, right? Next one.
Excuse me, sir. We think we can't see the slides if I am correct. Yes.
No?
Uh, Not, yes, now we can see.
Yeah,
Yes, I
can see,
think.
no? Is it all right now?
Yes, now can see.
Okay. Okay. So the now starting from the roadmap of this my mini discussion and lithium toxicity. I'm going to discuss lithium toxicity, acute and chronic, and in this division. And the second one will be the serotonin syndrome, which is commonly used drugs now. The SSRIs are commonly used drugs. So serotonin syndrome detection, early detection treatments is very important. And some of the occasion, lithium plus serotonin syndrome can appear in the same patient. And thirdly, I'm going to discuss about the neuroleptic malignant syndrome, which is the main deadly side effect of antipsychotic drugs. Okay, in addition to that, what my purpose is to teach the juniors regarding the toxidromic uh, relevant bedside examinations, right? Toxidromic guided bedside examination. This is very important. And I want to emphasize the identification of the toxic pattern and treatment options. I'm going to discuss about the treatment in a principle wise. So, regarding the gravity of the problem, nowadays the psychotropic drug medications are very widely used. This is because of aging process of our population. They are having more and more psychiatric illnesses. In addition to that, clinical psychiatry. All the base hospital, most of the base hospital now the psychiatrists are available. So they are using uh, for their management, right? And other thing is our drug policy. Some of the occasion patient may purchase drugs from over the counter. Over the counter issuing still, yeah, still and a clinical, as clinicians, that is also a big issue and big challenge to control this setup. And drugs toxicity is a significant cause of ICU admission and ICU care. They consume a lot of ICU resources. So that is also very take into consideration. And morbidity and mortality is higher due to arrhythmias and hypothermia and organ failure. Right? So this is the gravity of the problem. In addition to that, uh, who are the vulnerable group? Especially as I mentioned, our population is aging now. Elderly patients who are on long-term antipsychotic drugs, those people are, and psychotropic drugs, those people are very vulnerable. And most of our patients, elderly patients, may be having some sort of renal impairment or hepatic impairment. So drug elimination is impaired, mainly renal and some other occasion hepato and hepatorenal both. So the patient with end organ failure. And because of the complexity of the psychiatric illnesses, some patient may need multiple psychotropic drugs, that is combinations. Various kind of groups are added if patients the psychiatric illness is not controlled. That is also one of the risk factor of getting what do you call that complications. And recent escalation and de-escalation of the doses, that is also very important. Some of the occasion, if disease is not controlled, we might have to increase the dose. That is also one of the risk. And de-escalation also some of the occasion, recent adding, those are the risk factors and the people who are having vulnerable group. So this is very important. Bedside examination techniques and methods of patients who are suspecting poisoning, especially the psychotropic drugs I am concerning here. And first of all, so we have to train our juniors to identify the patient as a whole, holistic assessment. So the first of all, patient identify the abnormal vital signs, GCS, and those things should be documented. Documentation is not some of the occasion not happen in our juniors, so must teach our juniors how to document it correctly, vitals and GCS. In addition to that, temperature documentation, pulse, and mentioning the time and mention the pulse. In addition to that, blood pressure and respiratory rate and autonomic instability. Because autonomic instability I am mentioning here, that is one of the important physical sign we have to detect, because autonomic instability can cause cardiac arrhythmia and sudden cardiac death in a patient with suspecting poisoning. So we have to detect and document it, and stabilize the airway and breathing and circulation. Those are the basic things we do in our teaching sessions. And history, the previous speakers also discussed about the drug history and changes of recent medications and patient drug history. Some of the occasion, this might be not known by the patients or the guardians, and we must ask the patients to take any clinic notes if it is available at home until we do the basic resuscitation things. So, bedside nervous system examination, because most of the drugs, actually all the drugs act on some parts of the various parts of the nervous system. So each drug shows some specific neurological signs we can detect bedside clinically, and so we must familiar these physical signs. So we must do the targeted examination in our using our clinical sense. So evaluate the mental state of the patient, whether the patient is confused, whether the patient is agitated, the patient has features of delirium. Those things are very important. But by knowing only this one, we can come to a conclusion. In addition to that, any the other additional clinical parameters should be examined. Observe whether the patient is having tremor or any abnormal movement. So by examine in a correct pathway, so we can narrow down our clinical suspicions. So first of all, the confusion and delirium, and next the tremor and abnormal movement. So after the examining that one, so the next step will be the muscle tone. This is very important, especially the neuroleptic malignant syndrome in a muscle tone assessment, and tendon reflexes and the clonus. So those are bedside elicitable physical signs. Those are very hard physical signs, right? If this is present, that is very high chance of getting that toxicity. That is, I am telling the hard physical signs. So in assessment to that, checking the cerebral signs. So this is actually we are training our juniors and medical students since they are the third years, 30 onwards during their clinical sessions. So if those things are assessed in a bedside and documented, and so we can narrow down, in addition to that, changes in the pupil. So from the beginning, as this is important clinical slides, mental tests, as a generally we have to see the patient. In addition to that, ask the patient to sit on a bed and see the abnormal movements in the hands or abnormal movements in the body, and ask the patient to lie down and be relaxed, and ask the patient to help the check the muscle tone and check the tendon reflexes. Tendon reflexes are very important in lower limbs in serotonin syndrome. If tendon reflexes are positive and elicit the clonus also, right? So, in addition to that, cellular sign assessment. There are various cellular signs are there. I'm not going to discuss in detail the cellular signs. So, it's a very elicitable, easily elicitable clinical sign in our clinical medicine bedside. So, and papery changes and documentation. So, these clinical signs should be examined and documented on admission in your next ward round after 1 hour, 2 hour time. Your other juniors can re-examine and document it. So we can see the progression of the clinical signs, size of the pupil, the progression, physical signs, the cerebral signs which are mildly there, now it is more evident. So those things are also very important. And anatomical side in my topic, what my target is to discuss how the patient's physical signs correlate with the patient's the nervous system analytical side. So in lithium toxicity, main the cerebral organ, the brain organ is the cerebellum and the brainstem. So they disrupt the brain stem and the cerebellum cell structure. The physiologically disrupt their nerve transmission. And in a second one, in a serotonin syndrome, the brain stem is the key part which is affected that stimulate the serotonin receptors in their cells and then excessive serotonin activity which cause the detrimental physical signs causing might be fatal if it is not treated properly. And neuroleptic malignant syndrome, the main site of anatomy of the pathology is the basal ganglia. They block the drugs toxicity, they will block the dopamine pathways. So these if you see this in the this you can understand that these sites, depending on the sites, we can get a rough idea about the poison. And in addition to that, very importantly, most of the drugs causes autonomic dysfunction due to involvement of the hypothalamus. Hypothalamus involvement causing autonomic dysfunction. So this is also very important. So how to bedside detect the autonomic dysfunction? Fluctuation of the blood pressure, and in addition to that, postural drop, sweating, and those things should be, we must familiar our juniors. In addition to that, some other occasion, some patients they are having ingestion of polypharmacy, the multiple several classes of drugs, maybe lithium and maybe several kind of drugs which cause to serotonin syndrome, and some occasion some patients drugs, father's drugs, mother's drugs, and those. So in this occasion, physical signs are very complex, and in this occasion very difficult to take a clinical decision. So that is why holistically patient we can assess the patient and management regime should be started to stabilize the vitals. So here in a this is slide shows the actually mechanisms of physical signs. So the tremor and the ataxia, the one of the key physical signs in lithium toxicity, and tremor and due to tremor and ataxia due to lithium toxicity. And clonus is one of the sign, actually lower limb exaggerated reflexes and the clonus which indicate the serotonin syndrome, right? Serotonin excess or serotonin syndrome. So when you examine the patient's lower limb, especially if you experience the lead pipe rigidity that impressed the high chance of getting neuroleptic malignant syndrome, right? In addition to that, if muscle rigidity causes to hyperthermia because the sustained contraction of the muscle causing a lot of heat in the muscle and damage the muscle cell causing hypothermia. And as I mentioned earlier, hypothalamic dysfunction is a reflection of the autonomic instability. So when you examine the patient, if patient's dominant physical signs are tremor and ataxia, So there's a high degree of suspicion of lithium toxicity. If the main physical sign is clonus or hyperreflexia, that especially in the lower limbs, it indicates the serotonin syndrome. If the patient's main physical sign I want to emphasize here is rigidity, especially the lead pipe type rigidity that impress the suspicious of dopamine blockage or neuroliptic malignant syndrome. And muscle rigidity is one of the key signs associated with hypothermia and muscle rigidity with neuroliptic malignant syndrome according to their pathology. And autonomic instability which happen in a neuroleptic malignant syndrome as well as the serotonin syndrome. So we can get an idea about the and we can to manage accordingly. Few words about the lithium toxicity. First, the acute lithium toxicity. This is happening usually if a patient is another one, especially the mother, father taking lithium. In other the reason, other family member freshly taken lithium. So the patient is not a long-term lithium intaker. So this kind of patient develop GI symptoms dominant physical signs. That means they experience nausea, vomiting because lithium is GI toxic. That will the paralyze the GI cells and disrupt the GI cells various mechanisms and induce vomiting and nausea, maybe diarrhea as well. So the patient are high risk of getting fluid loss and metabolic derangement. So this is the acute lithium toxicity. If a patient has taken freshly the very high dose of lithium, patient might get cellular dysfunction features in the presence of GI symptoms. So in the presence of GI symptoms, so uh, if this patient has very high dose, this nervous system involvement also affect the with the presence of GI symptoms. So lithium level also helpful to clinical confirmation. Chronic lithium toxicity. So here neurological hallmark is the neurological symptoms dominate here. Actually, some patients may have persistently neurological signs because of chronic lithium toxicity for a long period of time may cause permanent brain damage. And neurological symptoms, as I mentioned, cognitive impairment, gaze disturbances. So you must ask the patient to walk in the ward with the help of others, and by the gait, you can detect some of the critical features. And this is actually precipitated by dehydration and the renal dysfunction. So some of the elderly, the senior citizens, if they are having poor family support, their intake also lacking, so high chance of getting lithium toxicity at home and rush to the hospital or emergency care. So the key thing here is serum lithium may be normal. Because of long-term lithium therapy, lithium will accumulate in the nerve system cells. So some of the occasion, if you check the serum lithium, despite the very imminent neurological physical signs, serum lithium may be normal. Having serum lithium normal is not a this is actually misguiding sign. So we have to consider the neurological plus the laboratory test as well in treating the patient. And if patient has neurological symptom dominant, even the normal level of serum lithium, but you must start the treatment without any delay. So hallmark of here is tremor plus ataxia and confusion. If a patient has tremor, ataxia, confusion, think about the lithium toxicity chronic. Serotonin syndrome, my second one. As you all of you know, depression is very common. In addition to the depression, there are other indications for SSRIs. So most of the occasion, our patient go doctor to doctor. Some of the occasion, if patient go to the GP, this is started as a GP level in Sri Lanka, right? Okay, the fluoxetine, sertraline, those kind of drugs. So some might start this sertraline, for example. So if patient is not feeling well, she might consult another the clinician. So he will start another one. If a patient consume two types of SSRIs, those are the patients who are having high chance of getting the serotonin syndrome. So excess serotogenic activity, the mechanism due to drug interactions. So in addition to the combination of SSRI, drug interactions are very common. Some patients may take other drugs for the other kind of illnesses. So this syndrome is characterized by agitation, hyperreflexia. This is the hallmark. This is the hallmark. Hyperreflexia, especially the lower limb. And if hyperreflexia is there, clonus may be positive and autonomic instability. So here the most significant thing is serotonin syndrome. The physical signs and clinical features will develop very rapidly after drug exposure, maybe hours. So your patient may be taking combinations of drug which catalyze the serotonin syndrome. Combination in the morning, very few hours time, patient may develop early symptoms. So this is the key thing in serotonin syndrome. After exposure, very rapidly patient take the physical signs. So the clonus and hyperreflexia and rapidity of onset, that is most of the occasion until proven otherwise, its history is there, serotonin syndrome. Neuroleptic malignant syndrome, third one. So this is by excess amount of dopamine in the blocked by the antipsychotic drugs. Excess amount of dopamine blocked. Because antipsychotic drugs also various kind of preparations are available in the clinical practice. Now older generation used to use earlier like haloperidol, chlorpromazine and those kind of drugs, and the newer generation drugs, olanzapine and quetiapine, those kind of drugs also available. So each drug carries various kind of level of clinical complications. So basically, the drug overdose cause excessive dopamine block by the nervous system. This is characterized by slow onset when compared to the previously the serotonin syndrome. If your patient exposed to the combination of drugs or any other contributory drug that can cause neuroleptic malignant syndrome, the physical signs develop days and days, maybe weeks and weeks. That is a diagnostic challenge. Some of the occasion, elderly patient, they are physical sign develop within days and weeks time. This will misguide your clinical diagnosis. Maybe infection you are treating as infection or you are treating as any other condition. So there should be high degree of suspicion. The drug history and the physical examination is very paramount important. And the hallmark of the is that creatinine phosphokinase is very high. And here the clinical picture is slow onset and led by rigidity and fever and high CPK until proven otherwise neuroleptic syndrome if history is compatible. So this is the quick comparison of lithium toxicity versus serotonin syndrome and the neuroleptic malignant syndrome. Here the lithium toxicity pupil may be normal, dominant cerebellar signs and confusion. Here the key thing is the dominant cerebellar signs and the confusion. Serotonin syndrome, here the dilated pupil, hyperreflexia and agitated and rapid onset when compared to the neuromuscular uh, this syndrome. And this one, third one, the key thing is the rigidity. Key thing is the rigidity, and patient might have drowsiness and fever. So the key things here, the cerebellar signs in lithium, hyperreflexia in serotonin syndrome, and the third one, the rigidity and the fever. So basically, so after doing your clinical assessment, the basic lab workup, which is available in most of the hospital above the basic base hospital, you can get an idea. Full blood count, neutrophil leukocytosis, which will usually happen in NMS, and electrolyte changes, most of the drugs. CPK will be high in NMS, creatinine in ABG. ABG is very important because by ABG we can get an idea. So most of the patients will get various kind of acidity changes. So that should be treated immediately with bicarbonate and correct amount of fluids. And I want to like to emphasize here, don't overload the bicarb of the patient, elderly patient especially, because they might have other comorbidities as well. So especially the patient with heart failure, they might go to the heart failure. In addition to that, it will cause intracellular acidosis if patient is given irrational doses of bicarbonate. And SGOT-PT also very important because of the toxic level of the drug that will damage. Ionized calcium also very important in diagnosis of some situation because in rhabdomyolysis, dystrophic calcification happening in the damaged cells, damaged muscle cells that can present as hypocalcemia causing seizure. This is one of there are so many case reports with rhabdomyolysis due to neuroleptic meningeal syndrome causing seizure. This is because of one reason is hypocalcemia. Hypomagnesium also very important. This is very important element in the magnesium is very important test in our clinical toxicology because this leads to hypomagnesemia leads to Torsades points due to long QT syndrome. This should be corrected. You must train your juniors how to check the long QT syndrome, how to assess it clinically in a ECG, and what are the treatment measures and those things. Lithium level also helpful. Some of the occasion it may be misguiding. So easily all the patients to be done ECG. By ECG, lot of we can get a lot of ideas in severe metabolic acidosis, just like a sinus tachycardia to other arrhythmias, malignant arrhythmias. So I'm not going to discuss about management part, all the things, all the principles, because of the limitation of the time. The practical principles of management I have mentioned here. Immediate stop the offending drugs. If you take the drugs, if you suspecting the drugs, stop it immediately and try to resuscitate the patient and stabilize the vital, as I mentioned previously. Intensely, patient should be monitored. This is the thing. Some of the occasion from our staff, this is missing because we are the intensive monitoring because we are trying to give the supportive therapy, the monitoring. By monitoring the patient, we can detect the biochemical changes in the patient's body from the investigation. In addition to that, monitoring of the physical signs. Gravity of the physical signs may be reduced with our treatment. Some of the occasion, if you are misguiding, we are treating other condition. Gravity of the physical signs may be progressive. So this is monitoring is very important. That should be done in a even in a ward that can be done, but better to give a ICU care or SDU care patient who are in a risk category and control the hypothermia and correct the hydration and correct the metabolic derangement and antidote. Some other occasion, if it is several, can be given, especially the cyproheptadine and hemodialysis if there are indications are there. So those are the principles to apply all our relevant topics today. So clinical scenarios, I would like to give, because the time is limited now, quick clinical scenario, three clinical scenarios. A 68 years old patient with bipolar affective disorders on lithium present with confusion, tremor, difficulty in walking for 3 days time. Recently, he was diagnosed as hypertension and general practitioner has started enropil and HCT. So this is the important drug interaction. So lithium and the AC inhibitors and HCT. On criminal examination, patient has tremor and gait problems, but there is no muscle rigidity. Serum lithium level and high in a very high level, and other investigation hyponatremia is there. So what is the mechanism here? This is commonly used drugs in AC inhibitors and HCT, the first line drug in hypertension. If a patient within a risk category, not all the patients develop this kind of presentation, but in a patients who are in a risk category, elderly patient on multiple drugs, organ failure, that can cause the poisoning in following mechanisms, right? So, because the lithium accumulate in the presence of enropil and HCT, so this is the mechanism, right? Because I'm not going to discuss in a detail. Second one, second clinical scenario, the patient who is having depression, 45 years old patient on sertraline, and he developed a back pain. So, general practitioner has started tramadol for the back pain, and the patient developed following physical signs within 6 hours time. So, progressively worsening physical sign, confusion with mild fever, agitated, and dilated pupil, diaphoresis, tachycardia. And when we are examining the patient, you notice that the patient has hyperreflexia and clonus. So what has happened here? So tramadol is the one, tramadol is the culprit. The combination of tramadol and sertraline may increase the serotonergic activity. So excessive serotonin will accumulate in the brainstem and spinal cord neuron. Oh, lastly, the third one, 65 years old patient with Parkinson's disease. Actually, this patient, elderly patient, Parkinson's disease, is on regular standard therapy, levodopa and carbidopa, and patient has complained insomnia for the general practitioner. And in our practice also, without any asking other drug history, some might start other drugs for the insomnia. Haloperidol usually given actually not the first line drug. And after 4 days, 5 days timing, patient develop fever and experience rigidity, altered level of consciousness, and liable blood pressure, and patient is dull looking. So this is actually typical clinical presentation of what you call that neuroleptic malignant syndrome due to the haloperidol. So, so patient CPK may be high. You should check neutrophil leukocytosis. This is misguided in some of the cases. If patient is clinically ill in this way, always we consider as a first differential diagnosis infection, urine infection like thing. So you must check the other physical signs as well and to get your conclusion. So, so basic mechanism I have mentioned here because of haloperidol in combination with the levodopa and carbidopa. So what are the non-toxic mimics? So most of the occasion the patients comes to us with a physical signs and their complaints. So one of the differential diagnosis of toxicological complication in this presentation is malignant catatonia. By history alone, you can detect malignant catatonia or ACTM poisoning, a separate thing, and CBS sepsis with delirium. The most of the elderly patient in a sepsis, they present with altered level of consciousness. So we have to think about whether it is sepsis, whether it is due to drug poisoning. This is clinically assessed. You can narrow down the clinical possibilities. Thyroid storm. So patient may present with tachycardia, sweating, and increased reflexes. So this is one of the typical presentation of what you call that serotonin syndrome also. So you must ask the history, past history of thyroid surgeries, whether the patient is on thyroxine, and you must see the goiter and heat streaks and meningoencephalopathies. Those are the non-toxic clinical mimics. So lastly, the take-home message. Actually, this is bedside. You can do a lot of services to the patients and the patient save the life and mortality the saving. So bedside examination is the cornerstone of most of the diagnosis. Toxirome guided early treatment is very essential. Drug interactions, always we must inquire the patient, we must think whether this is due to drug interactions. Not only here, in our other clinical practice also, drug interactions are very common now because of some of the occasion over the counter issuing of medical drugs. Early mechanism-based management may now adding the lab test also can start the specific treatment. So the clinical vigilance is essential in a psychotropic therapy because now most of the patients now in our elderly patient they are having undetected the depression and various kind of psychiatric behavior. So until proven otherwise, you must guess whether your patient is having drug poisoning in addition to the major medical diagnosis. Thank you very much for your kind attention.
Thank you very much, sir, for that informative lecture. I think the questions we will take at the end of the session. So we have one more lecture waiting, and after the the lectures done by the experts, I think it's my task to present the last lecture. So let me share my screen. Uh, Dr. Atula Kulasingham, if you can unshare the screen so I can share my screen. Stop sharing the screen. Thank you very much. So I'm going to do the last lecture of this webinar on management of recreational drug overdose. So I'm a senior lecturer in pharmacology from Faculty of Medicine, University of Rahuna, and also the assistant secretary of the Sri Lanka Association of Clinical Pharmacology and Therapeutics. So I think this is quite interesting topic nowadays, because we were always we are talking about the recreational drugs. And as we know that the growing tourist industry in Sri Lanka, and basically in the coastal areas, we see a lot of patients who come with this exposure to recreational drug overdose. So during this the 20 minutes, so we will try to recognize common recreational drugs that can come with toxic overdose, and to look at the key toxidromes associated with recreational drugs, because sometimes the patients will come to present to you, but they will not have any evidence of which drug they have been taking, or maybe they will always deny that they are taking overdose or taking any recreational drugs. And then we will briefly try to apply a systematic approach to these poison patients, maybe on individual basis. And then we will look at the evidence-based management, and also we'll try to recognize complications which require the critical care at the end of the lecture. So if you look at the global burden, I think this is from the World Health Organization global statistics from 2023 to 2025. People who use drugs, recreational drugs worldwide, around 296 to 316 million of the age category 15 to 64 years. And out of them, 39 to 64 million people have drug use disorders. And the alarming thing is that every year there are 600,000 deaths reported due to recreational drug use, particularly with the majority of opioid overdose. So what are these recreational drugs? So when we say recreational drugs, now some would argue it is not appropriate to use the term recreational drugs, because recreation is something that we do for our entertainment. It can be an adventure or hobby, but so is it worth using that term recreational drug? So some would like to use basically psychedelic, psychoactive drugs, or maybe some would say it's party drugs, the club drugs in general. So, but as for now, we commonly use the term recreational drugs. So there are four categories when it comes to recreational drugs that we are concerned. So analgesics, depressants, stimulants, and hallucinogens. So analgesics, basically the heroin, morphine, the opioid analgesics uh, fall into that category. Depressants are CNS depressants, so alcohol, barbiturates, other tranquilizers, and benzodiazepines. So they are really causing sedation and hypnosis. Stimulants, which will stimulate the central nervous system, and they have the sympathomimetic activity, sympathetic activity. So they are CNS stimulants like cocaine, methamphetamine, and ecstasy, MDMA. Hallucinogens. So basically, when we look at the hallucinogens, which cause hallucinations and also in euphoria, like LSDs and marijuana, ketamine. So these drugs fall into the category of hallucinogens. So how do they appear in the community? So they will not be labeled as their kind of generic name or the drug name that we know. Usually in the market or the industry, so they will be uh, labeled differently. So these party drugs, so they have these street names. So if you look at heroin, so heroin has multiple names: dope, horse, smack, junk, and you can see cocaine, coke, crack. So you can see multiple labels for each drug in the market. So if you look at nowadays we are talking about this ice, which is methamphetamine, crystal methamphetamine, so which is widely talked about, even and, more than heroin that we talk about methamphetamine or ice these days. So how do they in which form they are in the market? That is also important. And the importance of knowing these street names. Now we can actually Google it or ask from the chat GPT and get the name of the uh, original name of the street or the party drug. But it's important because the patients who come with the toxic exposure, the overdose, they will not know the general names that we use. So they will come with the street name. So it's also important to know what it really means. And so they will sometimes the patient will present unconscious, or some a relative or a friend will bring the patient to the emergency treatment unit, but we don't know what they have taken. So one way is to go through the circumstantial evidence that they have. So the patient will have this recreational drug in the form it is available. For example, ice can be a crystalline powder or crystals. So these are in this table you can see the drugs and the common form, the formulation, how they are available, in which form, and how they are administered by the drug user. So, for example, heroin is available as a powder, so it can be injected intravenously, intramuscularly, or subcutaneously, and it can also be smoked or snorted. LSD, again, it can be available as liquid drops. So the most famous, this ice is available as a crystal. So that's why it looks like ice. So that is called ice. And so you can see a list of drugs, recreational drugs, and each drug has multiple formulations and they are administered in different manners. So if you look at the routes of administration, so in this you can see which drugs are used as oral forms, which drugs are snorted, smoked, or injected. So it's also important because if a patient comes with needle track marks, so we should be vigilant what drug this patient could have taken, because it is available as an injectable form. So this slide, you can see the formulations of the drugs which are available. Like some will be available as tablets. Of the drugs which are the control drugs, they will be taken maybe over the counter or misused, and so they will come in tablets and capsules. And some will be powders, crystals, and also in the liquid or gel forms. So when a patient with recreational drug overdose presents, usually the approach is, as we have been talking over the last 1.5 hours, about the toxidromic approach of poison patients. So many of these patients will also come with these toxidrome picture. So they will have some constellation of symptoms and signs. So we can gather information by history and examination, and we can uh, correlate our collection of symptoms and signs into one particular toxidrome. So it's easy for us to make the diagnosis. But at the same time, we have to gather information from the evidence we have and also from the history given by the bystander or the patient themselves. So opioid toxidrome is due to heroin overdose, so they will present with opioid overdose. They will present with opioid toxidrome. So there are drugs which can give rise to sympathomimetic toxidrome, sedative hypnotic toxidrome, the sedatives, the CNS depressants usually uh, uh, result in sedative hypnotic toxidrome, and also some drug overdose will lead to serotonin syndrome. So briefly looking at the common toxidromes, so this have been discussed in the previous lectures as well. So if you know the basic parameters, the vital signs, the pupil, skin, and the mental status, so it's easy for us to understand the toxidrome. So it can be opioid toxidrome. So we are concerned about opioid toxidrome, sedative hypnotic toxidrome, sympathomimetic toxidrome, and also hallucinogenic toxidrome due to hallucinogens. Like in any other medication overdose, recreational drug overdose patients will also manage according to the, the the same clinical approach. So we will first stabilize the patient's airway breathing circulation. We need to have a rapid clinical and risk assessment and to identify the toxidrome during that assessment. And most of the time, we will not find antidotes, but if there are specific antidotes, we will use and initiate supportive care. Now, as we go along, you will see that the most of these recreational drug overdose, there's a limited place for activated charcoal and other gastric decontamination measures. So I would like to bring several patients for this discussion. So first patient story is here. 24-year-old male patient presented with reduced level of consciousness. He has shallow breathing at the time of presentation. And pupils were pinpoint. So examination revealed needle track marks on the forearm. So I would like to ask from the audience, what could this be? What recreational drug overdose this can be? You can type in the chat box if you want. So I would proceed without taking much time. So I think I can see likely options. So heroin is the possible recreational drug exposure here. So heroin is a morphine, diacetyl morphine, which is a prodrug, uh, which is converted to 6-monoacetyl morphine. And it acts on the mu opioid receptor as an agonist, activate the mu receptor and give rise to its effects. So it causes respiratory depression, sedation, euphoria, and analgesia. So clinical presentation would be opioid toxidrome, and they will be hypoxic at the time of presentation if they apneic, or because they will lose their airway protection reflexes due to CNS depression. And they will also have other manifestations due to opioid receptor stimulation. And as for any patient with overdose, we will use the basic clinical approach. And for heroin, of course, we have heroin or morphine, we have antidote, which is an opioid antagonist, naloxone. So we should consider titrated doses of naloxone, but for long-acting opioids, we would consider continuous naloxone infusion until patient recovers clinically. Right. So you can see that if you know the opioid toxidrome, so clinical presentation itself, we can make the diagnosis. So next story is about a 31-year-old male patient who presents with severe agitation and altered behavior, who is restless, aggressive, and complaining of palpitations. Pupils were dilated, sweating profusely, and he had tremors also. Examination, he has tachycardia and hypertension, and he has this substance with him. So what is this? Yes, I think it's correct answer. I can see the crystal meth. So this is ice. So crystal methamphetamine. So what is the toxidrome you see here? So basically, this is a CNS stimulant drug, which has a powerful CNS stimulant uh, ability, which release massive amount of monoamines, dopamine, norepinephrine, and serotonins. So all these work on the adrenoceptors in the sympathetic nervous system and stimulate, and there will be sympathetic overactivity. So presenting with sympathomimetic toxidrome. So patients, this patient will have uh, all the features of sympathetic overactivity. And there will be other features like rhabdomyolysis, chorioathetoid movements, abnormal hyperkinetic movements, and interestingly, they will also have aortic and carotid artery dissections, ICH, subarachnoid hemorrhage, they will have very high blood pressures, and paranoid psychosis. Uh, and they can have acute coronary syndrome due to severe vasospasm of the coronaries. So, like in any other patient, so we will go for this resuscitation, supportive care, and monitoring. And this overdose can be life-threatening. And what we see when we see a patient with hypertension and tachycardia, if the heart rate is very high, we would tend to give a beta blocker, which we should not attempt at all. So these patients, so what we first try is to give benzodiazepine to sedate the patient, and that will also improve the agitation. And we would give a vasodilator, uh, preferably a GTN, or maybe we can also try with calcium channel blockers. So if the patient has coronary artery vasospasms, so the calcium channel blockers, the nitrates will help to improve the coronary circulation by vasodilatation. And labetalol, it has a place because it has combined alpha and beta blockade. So if we give a beta blocker in the first place, so that will further patient will go into crisis. Sympathetic drive will further increase. There will be severe tachycardia and hypertensive crisis because when the beta blocker blocked the beta receptors, so there will be peripheral alpha adrenoceptors where on which the excessive monoamines will bind and work, leading to hypertensive crisis and severe tachyarrhythmias as well. So we would prefer uh, uh, labetalol because it has alpha blockers. Otherwise, we would prefer an alpha blocker like phentolamine if you want to control blood pressure in this kind of patient. And patients can also seizuring, so they will manage with benzodiazepines. And if they have psychosis, antipsychotics have a place, olanzapine and haloperidol. And these overdose, there's very little evidence for activated charcoal and enhanced elimination, and particularly we don't have any antidote. So that is about methamphetamine overdose. So next patient is a 40-year-old man presenting with anxiety and altered behavior who complains of palpitation, dizziness, and feeling of impending doom, and appears restless and mildly confused. Pupils are mildly dilated. An examination, tachycardia, conjunctival injection. Now, this is also looks like a sympathomimetic toxidrome. But if we further ask, or maybe from the circumferential evidence, you will see the patient might uh, disclose that is using smoking a recreational drug. So in this instance, it is weed, and you can see how the weed looks like. And I think all of us are aware of this drug, the plant, which is cannabis sativa. In uh, other countries, we use it marijuana. In Sri Lanka, we call the kansa or ganja. So cannabis. So this include cannabis. The active compound is this 9-tetrahydrocannabinol. and so which act on these cannabinoid receptors in the central nervous system, leading to presynaptic neurotransmitter inhibition of presynaptic neurotransmitter release, particularly glutamate and gamma aminobutyric acid. So this will increase the sedation and euphoria and CNS depression, and there is some sympathomimetic effect, mainly due to serotonergic effects. The long-term cannabinoid abuse will lead to cannabinoid hyperemesis syndrome, where patients will come with profuse, frequent vomiting. Again, the antiemetics will not be effective for cannabinoid hyperemesis, but the benzodiazepines are. So when the cannabinoid overdose is there, so for severe agitation, the drug is IV benzodiazepine. So we don't have any specific antidote for cannabinoid overdose as well. And because the way that the drug is used, it is smoked or snorted, so there's no place for gastric decontamination or enhanced elimination in this case. Apart from the plant derivative, we have synthetic cannabinoid receptor agonists, SCRA, being used or misused as recreational drugs, which will have the same effect, and in an overdose, which will have the same presentation. So I will move on to another case. A 32-year-old man presenting with emergency department, presented to emergency department with central chest pain, was crushing chest pain with palpitation, sweating, and shortness of breath. Patient looked very agitated. Pupils were dilated, tachycardic, hypertensive, and there is profuse diaphoresis. And the ECG was taken. I think all of us can identify what this ECG is. So you can see in the inferior leads there are ST elevations. So there's a ST elevation MI. And so we would consider a STEMI in this patient, but this can be a presentation of cocaine overdose. So cocaine will come like this as a powder, which can be snorted and smoked, and which can lead to coronary vasospasm, causing acute coronary events. Could be ST elevation MI, non-ST elevation MI. So other than that, they can also cause aortic dissection, carotid artery dissection, and they will present with sympathomimetic toxidrome, and basically due to the blockage of reuptake of monoamines at the presynaptic terminals, increasing the availability of dopamine, norepinephrine, and serotonin, which will lead to sympathetic activation. So how do we manage cocaine? So we will identify the cocaine induced myocardial infarction if it is the case. But again, we have benzodiazepines. We don't have any specific antidote. But if patient comes with sympathetic overactivity and refractory hypertension, we would consider phentermine, not a beta blocker. And for coronary vasospasms, or GTN also has a place. Coronary vasospasms, we would consider calcium channel blockers. But according to the guideline recommendations, it says for cocaine-induced acute coronary syndrome, the management is according to our standard protocols. So, there is a place for percutaneous coronary intervention as well. Sometimes there can be concomitant atherosclerosis leading to acute coronary event in cocaine overdose. But beta blockers are contraindicated, and calcium channel blockers we expect to reverse the coronary vasospasm. So there are two objectives in cocaine overdose: to minimize the sympathetic overactivity and to reduce the coronary vasospasm. And initially now this patient can also have sodium channel blockade because of the effect of cocaine. So it is recommended to give sodium bicarbonate as an initial dose in the beginning. And yes, and there are other complications as well. We will be expecting hypothermia, rhabdomyolysis, and ischemic colitis, and intracranial hemorrhages. So the last case is on this medication overdose. A 45-year-old man brought to hospital with a reduced level of consciousness, who is drowsy and difficult to arouse. His speech was slurred and he appears confused, and his pupils are normal in size and reactive to light. And no focal neurological deficit, but there was an empty bottle found at the bedside. So it's apparently diazepam. So this is benzodiazepine overdose. Sometimes this can be just the deliberate self-harm, but benzodiazepines are also misused, abused. So it can come as a recreational drug overdose. So benzodiazepines uh, are positive allosteric modulators of gamma-aminobutyric acid A receptors, so which will eventually leads to CNS depression by increasing the gamma-aminobutyric acid inhibitory neurotransmission. So that will lead to sedative hypnotic toxidrome. So the patients will come with sedation, hypnosis, CNS depression, maybe comatose at the time of presentation. So again, when at the time of presentation, it's very unlikely that the gastric decontamination or enhanced elimination will be helpful in here. Flumazenil is the antidote, but the problem with that is if a patient has the benzodiazepine dependence, so that patient can develop a seizure when we give flumazenil. Flumazenil is indicated when there is impending requirement for intubation and with severe respiratory depression. Otherwise, as for any benzodiazepine overdose, flumazenil is not indicated. And briefly about the pregabalin, gabapentin, because these are also misused medications, which also act on the central nervous system, these voltage-gated calcium channels, and this will reduce the calcium influx in the presynaptic neurons and reduce the excitatory neurotransmitters in the end. So leading to sedative hypnotic toxidrome again. But they can also have brief seizures, myoclonus as well, that we need to identify. And hemodialysis is effective in removing pregabalin as for enhanced elimination, but it's not usually indicated. But there is a place for hemodialysis in patients with renal impairment who have come with pregabalin overdose. Again, for seizures, benzodiazepines are the drugs of choice, but no antidote available. LSD, lysergic acid diethylamide. So this is again which increases the serotonin activity in the body. Leading to it works as an hallucinogen, leading to hallucinations, altered perception. So this is also identified as a psychedelic or psychoactive substance, and which also have some role to play on sympathetic overactivity. And patients, if they come with agitation, hyperactivity, benzodiazepine will be useful. And for hallucinations and delusional behavior, antipsychotics will be useful. But advice is to keep them in a quiet environment with low stimulant setting. Another one is gamma hydroxybutyrate, which acts on the GABA B receptors and gamma hydroxybutyrate receptors in the central nervous system. So they will inhibit the neurotransmission and lead to sort of sedative hypnotic effect. And again, no antidote, supportive care, and maintain hydration and benzodiazepine for agitation is the treatment modalities. Ketamine is another drug which is misused. It is an anesthetic drug, as we all know, and it will reduce the neuroexcitation, and because it acts as an NMDA receptor antagonist. and which lead to clinical effects, but they can also lead to sympathetic activity to some extent. So, giving rise to uh, agitation, confusion, and also seizures very rarely. And the ketamine overdose is managed similar to other sedative, other overdose with giving supportive care, benzodiazepines, and to keep the patient in a calm and low stimulation environment. So last part of this is about the place for monitoring of drug levels. So during this time, we talk about the common recreational drugs, how the patients can present with them, and what are our options to manage these patients at the acute presentation. So, so there are instances we tend to monitor the drug levels, particularly in urine and also in blood. So, what is the place for this drug monitoring in terms of treatment of recreational drug overdose? So, it is a metabolite or a parent compound that we check in urine, but it will only detect the exposure because it has no correlation with the degree of clinical toxicity. And most of the time, it provides qualitative results, so not the concentrations, but still, it is not correlating with the clinical toxicity. So, it is not a useful indicator for the management, but for medical legal purpose or maybe to in rehabilitation purpose. So, monitoring of recreational drug levels would be useful. Some drugs are difficult to detect in urine, like LSDs and GHBs as well. And the detection windows are also 1 to 3 days. So you can see most of the time it is 1 to 3 days of all these drugs, the detectability in urine. Most importantly, we should anticipate the complications of drug overdose because these can be even life-threatening. Some overdose would not be lethal, but most of the time they are leading to life-threatening complications. So neurological complications, respiratory arrest, arrhythmias, MIs, aortic dissections, and even rhabdomyolysis, acute kidney injury. So we have to be very uh, vigilant and also proactive to detect these complications. So we should not left these patients behind after the initial management. So the key take-home messages of this brief lecture would be that the IV benzodiazepine is a key to management of many psychoactive when a patient comes in psychoactive state in the absence of specific antidotes. Mainly if a patient comes with agitation, so we should not be hesitating to give benzodiazepines. And for sympathetic overactivity, there is no place for beta blockers, which will further worsen the condition. But rather than we would look for other options, starting with the benzodiazepine. And if there's persistent cardiovascular compromise, there is a place for alpha blockers like phentolamines, nitrates, and alpha beta mix combined blockers like labetalol. Most of the time, the route of administration is different. So maybe inhalation, intravenous, subcutaneous, or smoking, snorting. So very hardly we see a place for gastric decontamination and enhanced elimination. And measuring urine drug levels has no therapeutic validity. So that is the take-home messages that I would like to give. And so we will see a lot of patients with the growing advances and the tourist industry and the globalization. A lot of drugs are available, and patients will present with medication and recreational drug overdose. So these are my references, and I would like to thank the Sri Lanka Association of Clinical Pharmacology and Therapeutics, as well as Sri Lanka College of Internal Medicine for giving me the opportunity to deliver this lecture. And I think now it is time for us to go for the Q&A session. Thank you very much. I think we can see questions in the chat box. I would like to take one or two, maybe a couple of questions for discussion. Uh, some of the questions have already been answered. I think if we start from the lower end. I think I would like to, for all of us to see, I would like to direct this question forwarded to Priyadarshini Madam. Again, is it okay? What's the protocol once patient has gotten a reaction to NEC? Methadone no longer an alternative. Madam, would you like to?
Yes. Thank you, Sahan. I think I have already answered that question in the chat forum as well. So reaction to NAC is actually they are anaphylactoid reactions. They are not IgE mediated anaphylactic reactions, which are more serious and life threatening. This is due to release of histamine, but not through mast cell bound IgE, resulting in massive histamine release, which we refer to as anaphylactic reactions. So usually you can give an antihistamine. And in this situation, I think it has been mentioned that the patient had hypotension. So you can give antihistamine intravenously, and then you can restart actually after stopping the N-acetylcysteine, you can restart it at a much lower rate while carefully observing the patient. And therefore, if the patient further develops, drop in blood pressure, you can, of course, stop the infusion. I think he has said this is a real case. And then, they actually stop they actually stopped the further infusion, and patient had been all right. Then there was another question, I think, for me, asking why do you start the nomogram at 4 hours, because at 4 and not before that, and why do you check the blood levels after 4 hours? Because before 4 hours the drug may be still being absorbed, and therefore you will not get the maximum concentration if you measure the drug level before 4 hours. So that's why it is recommended to measure the drug level if you are measuring at between 4 to 16 hour window. And in fact, if the patient has had a staggered overdose, that is more than one injection, it is recommended that you have a repeat blood level also, so because the drug may be still being absorbed. So I think those are the two questions that were directed to me. Thank you.
Thank you, ma'am. So I think there's one last question available here. Due to the risk of respiratory depression, what is preferred to use in management of agitation in recreational drug or alcohol misuse? Is it benzodiazepine or haloperidol? I think that depends on the clinical scenario, but usually the first line drug is giving IV benzodiazepines, and so you have to always outweigh the risk versus benefits as well. And given the situation, I think still the agitation is best managed with benzodiazepines rather than the antipsychotics. And in the Yes, please.
Sahan, I would like to sort of, update some information in that, regarding to paracetamol management of paracetamol, because this question is being always asked, when we manage these patients with NAC infusion, when to really stop it. Sometimes we see patients who are having very high AST, ALT levels, like, 8,000, 20,000, and like when we going to continue NAC, because we don't have an exact cutoff value to stop the infusion. So there are actually slow responders. I think Dr. Prof. Priyadashini Kalapathi would also agree with me. So since there's no consensus that we during the Asia Pacific Association Medical Toxicology Conference, that this was being discussed. So what they have suggested is, if your AST actually will fall before ALT levels when it is falling. So what you will do is, if your AST, the maximum, the AST level which has gone up, say it's about 20,000. So from that, if the next AST level has come down by 20%, to consider stopping the NAC infusion. Otherwise, we would continue NAC for forever and ever. So since there are slow responders.
Thank you. Thank you very much, Madhuvanti. Yes, for that addition. Yes, I didn't go into details of very, high doses in the interest of time. Yes, but I think guidelines say that if there is a reduction of 25% from the AST/ALT, then you can consider stopping the NAC rather than indefinitely continuing. Thank you very much for the addition, Madhuvanti. Yes, thank you.
Thank you very much, madam. Thank you, madam, for the update as well. So I think we don't have any questions in the chat box to see. So in the interest of time, and also I think it's time for us to conclude this webinar on clinical toxicology. So it's my pleasure to propose a vote of thanks representing both the Sri Lanka Association of Clinical Pharmacology and Therapeutics and Sri Lanka College of Internal Medicine. In the meantime, I would like to request from you to scan the QR code and fill the Google form for you to receive the CPD e-certificate, which is displayed here. So I would like to express my sincere thanks, the gratitude to Professor Chandani Vanigatunga, the President of Sri Lanka Association of Clinical Pharmacology and Therapeutics, and Dr. Madhuvanti Hettiarachchi, the President of Sri Lanka College of Internal Medicine, for the guidance and the support given in this academic collaboration. I think it has been a very useful and impactful webinar that we delivered today. And I extend my heartfelt appreciation to our speakers who have shared their knowledge and expertise generously. To Dr. Madhuvanti Hettiarachchi for delivering the lecture on approach to management of medication overdose, Professor Priyadashini Kalapathi for the enlightening presentation on the evidence-based management of paracetamol toxicity, and Dr. Atula Kulasinghe for his valuable insights on psychotropic drug toxicity, toxidrome-guided mechanistic approach, and so all those who have contributed to make this webinar a success. And I wish to thank all the participants who have enthusiastically joined this webinar. And I think the knowledge you shared gathered today you would disseminate in the future. And thank you very much, all of you, for your engagement and attention. And I wish you all a very pleasant day ahead. Thank you.